Hi Venus, this is Dr. Srikanth from Team MDS CONQUER. Now we are going to start Endodontics. In this first content, I'll be discussing very important aspects about the topic diagnosis. Okay, and this topic diagnosis will cover diagnosis from all the aspects, like diagnosis of almost all the subjects directly or indirectly. So the first important aspect in the diagnosis is you need to make a note about the symptoms. Okay, so coming to the symptoms, so we have two symptoms. One is subjective and second one is objective. Okay, so one is subjective and second one is objective. Most of the subjective symptoms are they'll be given by the patient. Okay, so in the form of an information, so they'll be given by the patient. And coming to the objective symptoms, the objective symptoms will be known by the dentist by using some like tests or with some basic information. Okay, so that is the subjective are basically they are given by the patient, whereas coming to the objective part will be taken by the dentist by various tests or exams. So that is about the symptoms. And coming to the subjective, the most important subjective symptom that is given by the patient in the dentistry is pain. Okay, hope you know. Okay, so pain, and pain is basically due to nerves, and you know that enamel is the one that doesn't have any nerves in it. Okay, so most of your nerve related pain is basically due to the pulp. And I have clearly given you the clear-cut idea like how what are the nerves that are present in the body and what are the nerves that are present in the dental pulp in my video, which is in the medicine physiology part, that is the classification of nerves. So I don't want to talk anything related to pains of dental origin. Okay, pains of dental origin will be on the same side, that is the ipsilateral side, and will never cross the midline. Okay, so that's a very important thing. So for your information sake, I have added this particular slide which contains the information of the nerves that are present in the pulp. So as already discussed, the predominant nerves that are present in the pulp are A delta and the C fibers. Okay, so all these points of A delta and C fibers are very, very, very important in examination point of view. Okay, so you can pause the video and just check all the points, that is the diameter, conduction velocity, where they are present. Okay, what is the mode of pain they carry, and all these are very, very important points to be added. Okay, so next comes is as already discussed, the symptoms are of subjective and objective, and subjective comes like most of your subjective signs are related to the pain. And coming to the next part, that is the objective you need to go with the few examinations or few tests. Okay, in that the first test we're going to talk about the percussion. Okay, so this is a percussion test. So percussion is a one that is going to, like, how well we are responding to the percussion test gives an idea about the degree of the inflammation that is associated. So one percussion test that is most commonly used, I hope most of you are very, very familiar with this that is called as tooth sloth. Okay, it's also called as rubber wheel test. Okay, so they use rubber wheel here similar to this is a tooth slot. Okay, or it can be called as bite test. You'll ask the patient to bite on this slot. Whenever the patient responds positive, okay, so whenever patient responds pain upon biting, then you can diagnose it as apical periodontitis, means inflammation at the apex. And whenever the patient is negative, means not negative exactly, it is whenever the patient has a relief of pain. Okay, when the patient has a relief of pain, then you can diagnose it as cracked tooth syndrome. Okay, so that's very important things to be added related to this particular test. Okay, this test is also called as tooth slot test or rubber wheel test or bite test. Whenever you have pain on bite, that is called as apical periodontitis. Whenever you have relief of pain on the bite, then that is called as cracked tooth syndrome. The next comes, I hope you know this is called as palpation. Okay, palpation can be done at different areas. Okay, most of you are familiar with different types of palpations. External palpation, you'll have your lymph nodes will be palpated internally. Your periapical area or the vestibular areas are palpated. Whenever you have a vestibular tenderness, you can diagnose it as an acute inflammation case, like you can diagnose it as an abscess or something. So you need to palpate. So what are the features of palpation? So whenever you have an acute infections, okay, whenever you have an acute infections, the palpation signs will be tender. The patient will have pain, and sometimes it may be mobile. Okay, and they are enlarged. Okay, so that these are the acute signs. And when coming to the chronic signs, what happens in the chronic situation? In the chronic situation, they may not be tender. It is non-tender. Okay, it can be mobile and it can be enlarged. So when you take TB into consideration, like tuberculosis lymph nodes, okay, I hope you remember when we are talking about this, we are going to talk, we are done with the talk about this related to the TB lymph nodes. They're matted lymph nodes, means a pack of group of lymph nodes. So they can be called as matted lymph nodes. They are non-tender, you don't have any pain. Okay, so such category of lymph nodes, they comes under the TB lymph nodes, or like they can ask you the node that is going to infected when a particular teeth is associated with the. Okay, we're going to learn about this in space infections in the oral surgery, but just like for example, if it is a lower anterior teeth, your submental lymph nodes are going to be palpated or inflamed. Okay, if it is like a posterior teeth, okay, if it is like posterior maxillary teeth, posterior upper teeth, your submaxillary lymph nodes are infected or palpated. Okay, so basing upon this, you're going to judge which type of lymph nodes and everything. So this is how the external palpation is done. Internally, that is vestibular tenderness, we call it as. External, this is how the lymph nodes are palpated, and different lymph nodes palpation will give an idea that this teeth may get infected. Okay, right? So clear, right? The next comes is some radiographic information is again required, mostly as per the as per the suggestions. You need to take a minimum 2 views of the same teeth. Okay, so that you can change the angulation by which you'll get to know like what are the things that are associated with the particular abnormality. You can see here the difference in the normal PDL. Okay, this is a normal PDL. Okay, whereas here you can see the laminar dura. Whereas whenever you have a periapical infection, okay, so you can see that there is widening. The PDL space is being widening. You can see the widening PDL space here, whereas here you have a normal PDL space. And you can see the loss of laminar dura, whereas an opaque layer is clearly visible here. Here you don't have any opaque layer. Okay, you can see the loss of laminar dura. So loss of laminar dura is one of the most common sign that is seen whenever the infection is going to start. Like the first sign that seen on the radiograph, and what you can appreciate is loss of laminar dura at the apical region. Okay, so I mean, this is again a radiology related stuff. This is called as inverted Y shape. Hope you remember inverted, that is called as inverted Y line of Eanes. Inverted Y line of Eanes, that is called as. That is nothing but an overlapping border of the nasal fossa and the maxillary sinus. Okay, so there is an overlapping of, this is a maxillary sinus, this is in a nasal fossa. Both are overlapped to form a Y line, inverted Y line. Okay, this is preferably seen at the maxillary canine area. Okay, so radiology related stuff, just for the information sake I have added here. Okay, the next comes is regular things I don't want to discuss much. Okay, a bite wing radiograph is of less use in endo. Why? Because you need a periapical area. In bite wing, you don't get the periapical area. Most of your infections will be associated with the periapical region, right? So bite wing of less use in endo. IOPA is useful more. Okay. So techniques, like this technique is the slope technique. Same side, lingual, opposite side, buccal. Okay, that's what the slope rule says. And you're very familiar. We are going to discuss this much detail when we are talking about oral radiology. And this slope rule is also called as cone shift rule, because by shifting the cone, if the object is moving onto the same side, then the object will be present on the lingual side, and if the object is moving towards the opposite side in the direction of the cone shift, then it will be present on the buccal side. That's what the cone shift technique says. That cone shift, other name is cone shift technique, or it can be called as tube shift technique. Tube is nothing but cone, right? You have a tube in X-ray film, so that is you're going to change the direction of the tube. That is called as tube shift technique. It's also called as Clark's technique. It also called as buccal object rule technique. Okay, so these are the other names of the slope technique. Okay, so that's important thing to be added. And there is one more variation which is exclusively used in endo. That's a slope variation. This is a very simple technique where you are going to change the angulation of the cone by 20 to 30 degrees. Okay, so in this WallTrans technique, what you're going to take, you're going to expose it. You're going to expose your cone at a particular angulation. Then you change the angulation. By 20 degrees. Okay, to this angulation. So by changing the angulation by 20 to 30, you are going to expose again. So you'll have two X-rays at a different angulation. So the change of X-rays, this technique is called as WallTrans technique. You can see in this radiograph, if you see in this pic, you have how many, you have inserted four files. That is different scenario. But on the radiograph, what happens is they're overlapped. Right? So you can see two canals only, officially. Okay, but when you change the angulation by 20 degrees to 30 degrees, okay, you will not see any overlapping. You can see all the four canals. This change in the angulation in this technique is called as WallTrans technique. Nothing but a similar pattern of slopes technique, but it's more often called as the WallTrans the technique. Okay, so you can apply the slope technique, or there is something called as the other technique called as MBD rule. Okay, so the MBD rule is very, very simple. That is Ingles MBD rule. Any of these techniques, the main mode of the outcome is the same. Means you are trying to change the angulation by which you are overcoming this overlapping of the canals or the overlapping of the roots, by which you will get more information about the anatomy. Okay, next comes, again, this is the most commonly asked question. So whenever you observe a radiograph, okay, or you observe a canal, whenever there is a sharp change in the radiolucency within the canal, then you can call it as a fast break. Okay, so what fast break gives an idea? The fast break gives an idea that single canal has changed into, is branched. Okay, so you can predict one more canal. Okay, you can, whenever you, for example, you can see here there is a good radiolucency, but suddenly the radiolucency has dropped here. Suddenly there is sudden drop in the radiolucency, and similarly here also you can see radiolucency is good here, but if you see the radiolucency has dropped here. So sudden change in the radiolucency within the canal, or sudden change in the density within the canal, will definitely gives an idea or a prediction that there may be some additional canal, extra canal. Okay, so that is called as fast break. One more important aspect that you have to make a note when we are talking about the radiology related stuff. Okay, so this is most of you are familiar, most commonly, and you will encounter this in your perio, that is called as classification of furcation. Okay, classification of furcations. So this is called as a Glickman's classification. So Glickman has divided into class 1, class 2, class 3 and class 4. Most of you are very familiar with this. Okay, so the furcation probe cannot enter the furcation area. Okay, so basically when you try to probe it, the furcation probe will not enter the furcation area. That is about your class 1. And in the class 2, the probe is able to partially enter the furcation and it extends approximately 1/3 of the width of the tooth, but it is not able to pass completely through the furcation. That is called as class 2. First, it doesn't enter. Second, it enters partially. The next comes is the third one. Third one is the furcation. The furcation, I mean, here it's not entering partially, it's going to enter. It's going to enter, and that's what the difference. And it's if you see the mandibular molars and the maxillary molars, the probe that passes between the mesobuccal and the distobuccal root and touches the palatal root, that's in the maxillary. And in the mandibular, the probe passes completely through the furcation between the mesial and the distal roots in the case of mandibular molars. And coming to the fourth one is same as the third one, except the entrance of the furcation is visible clinically with a gingival recession. Here it's not visible clinically, but it moves from here to there. Here it is visible clinically and it moves from here to there. So that's the difference between the four classes of furcations. Here it will not go. Here it will go partially. Here it goes completely. Here it goes completely, which is visible to you clinically. Okay, so these are the four classes of furcations that you have to make a note. The next comes is the testing, the pulp vitality. Like more familiarly, they are called as pulp sensibility tests. Okay, what are these called as? Pulp sensibility tests. They are called as pulp sensibility tests. Okay, that is cold test. These are called as thermal tests, cold and heat. And electrical test, that is called as EPT. So coming to the, okay, so in the thermal test you have cold test, and the second one you have the heat test. Okay, so cold test, heat test. And I hope you are very familiar with the cold test and heat test. Whenever you're doing a cold test and a heat test, make sure you take a control teeth. Okay, so your control teeth is going to be the adjacent and the contralateral teeth. Okay, so that's a question again. The control teeth is the adjacent and the contralateral teeth. And whenever you talk about this cold test or a heat test, the most commonly asked questions for you is the temperatures. Okay, these are the different temperatures which I have collected personally. Okay, so the heat test, the most commonly asked question is the temperature that is used in the heat test is 65.5 degrees centigrade. And most commonly asked question is carbon dioxide snow or dry ice. The temperature is minus 78 degrees centigrade. Ice, well known, that is 0 degrees centigrade. Endo ice is minus 30 degrees centigrade. So most of your clinical scenarios, they give endo ice. Okay, the wording they give is they talk about the endo ice. Okay, and carbon dioxide snow ice is a thing that is regularly used in case of your crowns, full crowns. You'll have full crown or heavy restorations where you can use carbon dioxide snow, that is minus 78 degrees centigrade. So they can ask you blood is stored at the temperature of other peculiar question when you're talking about physiology, that is 4 degrees centigrade. They can ask you the platelets are stored at a temperature of. Platelets are regularly stored at a temperature of room temperature. They're stored at room temperature. So the room temperature is 20 to 25 degrees centigrade. So they can ask you oral polio vaccine is stored at a temperature of minus 20 degrees centigrade. Freezident, okay, is again a type of like cold test, that is the temperature is minus 20 degrees centigrade. Okay, so please do make a note about these values. Regularly asked, you can see questions regularly on this numerical system. The next comes, I was talking about the EPT, that is electrical pulp test. Okay, there are different types of electrical pulp tests that are regularly used. Okay, so I mean, like the important points that we have to make a note when you're talking about the electrical pulp test is it is basically the basic mechanism is you're going to give some electrical excitation for the neural elements that are present in the pulp. A positive response indicates the presence of nerves. Okay, and a negative response indicates the vitality. So whenever you have positive response, you can predict it as a vital pulp, a kind of vital pulp. A negative response or no response is a non-vital pulp. Okay, so that is the utmost important point that you have to make a note when we're talking about this particular thing. Okay, so what happens in the next level? The next level is So most of your questions will move around like the electrolyte, because whenever you go for EPT you need to apply electrolyte. I hope most of you have done this in your colleges. Okay, so the electrolyte, you have to use a uh, I mean like toothpaste. Okay, so the toothpaste is called as Grossman's toothpaste, and you regularly used a colloidal graphite. Colloidal graphite is regularly used as an electrolyte in this situation. And make sure whenever you do this particular type of EPT, make sure that you don't wear glove. Okay, because glove is going to act as an non-conductor. It doesn't conduct. Okay, so circuit will not be formed. So make sure whenever you do this particular test on the patient, don't wear a glove, because through your body the circuit is going to form. And make sure EPT is contraindicated in the patients with cardiac pacemakers. So it's contraindicated with the patients having cardiac pacemakers. Even your cardiac pacemakers, it is contraindicated. Even your apex locators, even your apex locators, because apex locators also they work with the formation of a circuit. So even your apex locators are contraindicated whenever the patient is having the cardiac pacemaker. So it's very, very important. Your apex locators as well as your electrical pulp tests are contraindicated in the patients who has cardiac pacemakers in them. Okay, that's an important aspect to be noted. So how this EPT is going to respond to the different situations? I mean, basically you have a reversible pulpitis, you have a irreversible pulpitis, or you have hyperplastic pulpitis, right? So how they respond to these three categories is an important aspect. So in the reversible pulpitis, the tooth responds to less amount of current than normal. Okay, so it responds to the less current than the normal. Whereas in coming to the irreversible pulpitis, it requires more current. It requires more current to respond. And when you take this hyperplastic pulpitis, when we're talking about the diseases of pulp, I'll be discussing in detail about the hyperplastic pulpitis. What happens in hyperplastic pulpitis is the number of nerves decreases in hyperplastic pulpitis, whereas the vascular supply will increase. So that's the reason why, as the number of nerves decreases, there is less pain in hyperplastic pulpitis and there is more bleeding. So immediately whenever you touch, it bleeds fast. So there is more bleeding. So whenever you have less number of pulp, whenever you have less number of nerves in the pulp, what happens? The pulp polyp, that is hyperplastic pulpitis, will contain less number of nerve supply than the normal pulp, and also so because they contain less number of nerve, they require more current to give a pain. Okay, that's the sign that you have to make a note when you're talking about hyperplastic pulpitis. Reversible pulpitis, less current. Irreversible pulpitis, because nerves are damaged, more current is required. Hyperplastic pulpitis, they have less number of nerves, so more current is required to elicit the pain. So okay, next one is the location where you have to keep this tip is an important aspect. Okay, so you have to keep this particular tape in the anatomical location where there is high density of nerves. So it will be differ for anterior teeth and it will be differing for the posterior teeth. For example, if it is an anterior teeth, the anterior teeth, which part of anterior teeth will have more nerve supply is incisal 1/3. So it's incisal 1/3. Whereas coming to the posterior teeth, it's going to be the middle 1/3. The middle 1/3 is going to have the more density of the nerves. Okay, so it is upper 1/3, the posterior is the middle 1/3. So other important aspect that you have to make a note is about the defects in this test. Okay, so in few cases you will get false positive. In few other cases you will get false negative. So these are the problems with this. So at which conditions you will have false positive and which conditions you will have false negative is again a most commonly asked question. So what happens, the false positive can be seen in the cases when you have a moist necrotic pulp. So pulp is dead, but it is moist. So moist is going to allow the current. Okay, so the pulp is dead, but you will have a positive result in this case. Or whenever you have a partial necrosis, for example, if it's a multi-rooted teeth, you have a necrosis in two roots, and the two roots the pulp is vital. So this is going to give a false result. So whenever you have a partial necrosis in a multi-rooted teeth, it's going to give the result. So whenever the electrode is going to contact the gingival tissue or whenever it's going to contact the wet surfaces, it's going to give a positive result. Whenever the tooth is having an acute alveolar abscess, it's going to give a positive result. Or whenever the patient is too anxious, hypertensive or hyper reactive patients, okay, without touching they give pain and telling that it's vital. So such conditions comes under the false positive. So what happens in the false negative? If it is a calcified canal, it's going to give false negative. Or the patient is having high threshold level of pain, it's give a positive result. Or the patient is having a painkiller before testing, it gives a false result. Or recently erupted teeth with immature apex, because the nerve system is not well developed, it's going to give a false result. Okay, or if the EPT is not working at all, if it is not working at all, it gives a false result. Or recently traumatic teeth is going to give a false result. So they can ask you in which of the following conditions you have a positive, false positive, or in which of the following conditions you have a false negative. Is the most commonly asked question for you. So just make a note of it. So they can ask you this type of question. Type of pulp testing used in this case. You can see this case is a full crown restoration. So full crown restorations, what is the pulp test that you have to use is carbon dioxide snow, that is minus 78 degrees carbon dioxide snow that you have to use when you're going for this particular type of test. Okay, so before going into this, I just want to add a note about your anesthetic test. So anesthetic test is basically done by an intraligamentary, and very few cases they can go for the mode of injection as an infiltration. So basically the anesthetic test is useful, first of all useful to identify the maxillary teeth and the mandibular teeth, which arch it belongs. And you have to do this test from the posterior tooth to anterior teeth, by which you're going to anesthetize each and every teeth, by which you're going to rule out that particular teeth, and you're going to come out with the ultimate teeth which has the issue. That is the anesthetic test. And coming to the test cavity is you're going to prepare a cavity basing upon which you will tell the vitality of the teeth. So that's going to be the last option. Means you're destroying, means it is, and you're causing some trauma to the teeth. So basically anesthetic cavity, what you have to do is you have to drill the cavity in an unanesthetized teeth. Okay, so test cavity is a cavity that is done, okay, drilling a teeth without a water coolant. Make a note, the points to be added is without water coolant, because the heat has to cause the pain. Without a water coolant and without giving LA, you have to, without giving LA. So this has to be done, these two has to be done. Then the patient complains of pain, by which you can tell that you have some sensitivity towards the particular thing. Okay, the next comes is the zero radiography. Okay, so what happens, like few important things, of course these are very essential things that you have to make a note when we are talking about your oral radiology. But my concern is I want to cover these aspects in endo point of view. Okay, so in endodontics point of view, I feel like I need to cover the reliable stuff of this. So what happens in zero radiography? Zero radiography is something called as an electrostatic imaging system that uses a uniform charged X-ray sensitive selenium alloy photoreceptor. Okay, so this is an electrostatic. So points to be added is this is an electrostatic imaging system. This is an electrostatic imaging system in which they regularly used selenium coated photoreceptor plate. So what is the material? Selenium. Mostly selenium, but in very few cases they can use aluminum also. But make a note, selenium is an important point. Electrostatic imaging system is an important point. And this procedure is very rapid. It is a very rapid procedure which is done in 20 to 25 seconds. Time duration is very important, 20 to 25 seconds. And the utmost important point about this in examination point of view is it has a peculiar feature that is called as edge enhancement property. So it has edge enhancement property, and it also has a sharper contrast. So these are the advantages that are associated. And when you're talking about the exposure, the radiation levels or radiation exposure is also less. Clear? So the three important points that you have to make a note about this is very rapid. That is, it takes place in a duration of 20 to 25 seconds. The second one is edge enhancement property. It has a sharper contrast, and the radiation exposure is very, very less. So coming to the disadvantages that is associated with this is, the disadvantages that are basically associated with this is it has a greater degree of artifacts. So whenever you compare to the conventional radiographs, you have more degree of artifacts here. And whenever you have a larger areas of bone, means more than 2 centimeters, are shown better with conventional radiographs, than the zero radiographs. Whenever you have a larger defects, so this cannot be a good option for this. So what are the advantages? So the advantages are rapid procedure, 20 to 25 seconds, edge enhancement property, sharp contrast, decreasing the radiation exposure. The disadvantages are high degree of artifacts and larger defects of bones cannot be clearly appreciated when you compare with a normal conventional radiograph. So that's about the zero radiography that you have to make a note. The second one is RVG. Hope you are very familiar because most of your colleges now started using this. So that is called as RVG. That is nothing but radio visivography. So I don't want to talk much about this. So the main advantage is decreasing in the exposure. So because we talk more about this in your oral radiology, decreasing exposure. And the main disadvantage of like when you compare the resolution, so coming to the disadvantages, the resolution is less. So the clarity of the image is less when you compare with the conventional radiograph. And the second one is expensive. And the third one is soft tissue images are not clear when compared with the conventional. Soft tissues are not clear when you compare with the conventional. That is about RVG. The next comes is digital subtraction radiography. So digital subtraction radiography is going to be like the word clearly says subtraction, means you're going to take two radiographs, radiograph 1, radiograph 2, radiograph 1, radiograph 2, after a duration of time. For example, the duration between these two radiographs and these two radiographs is some 3 months. And 3 months, and you are going to compare the two radiographs by subtracting one from other, by which you're going to know the prognosis of the teeth. I hope you're very clear, right? So area of focus will be taken and the subtraction will be done, and you will get to know what is better property, like what are the changes. So easily you can use this particular thing for the follow-up of a particular case. So that is all about the digital subtraction radiography. So what this basically, I mean, like the use of this is basically in most of the follow-up cases. Okay, so the first image what you're going to take is going to be considered as a baseline, and followed by a duration of type. You're going to take a follow-up radiograph. This is called as a follow-up radiograph, and you're going to register them and compare the differences between the two images. That is, you're going to see the difference between the radiographic density of the two images. For example, if the outcome, if you have a bright area, then that is called as the gain. There is some deposition that has occurred. If you have a dark area, then there is a loss of the density. Okay, so and make sure the most important thing that you have to do is the projection geometry should be same, because the same way the X-ray should be, the landmarks and everything which were kept as a reference for the baseline radiograph and for the follow-up radiograph should be same, so that the subtraction process can be used. So the main disadvantage of this technique is projection geometries are very difficult to follow, and that can lead to some sort of error. So that's all about the digital subtraction radiography. So at this particular point, we need to make a note about PAI scores or PAI index. That is nothing but called as Periapical Index. So what happens in Periapical Index? So in Periapical Index, we have 1, 2, 3, 4, 5 scorings. I think in 2017 or 18 they have given what is Periapical Index 3 description. So one is normal periapical structures. Okay, so this is normal periapical structure, and whereas 2, there is small change in the bony structure. Okay, you have a small change in the surrounding bone. Whereas coming to the 3, there is change in the bony structure with mineral loss. You can appreciate a very huge mineral loss. Okay, and the 4th one is periodontitis with well-defined radiolucency. You'll have periodontitis also with well-defined radiolucency. And the 5th one is severe periodontitis with more intensified features. So make a note about this PI index, that is called as Periapical Index. The next comes is the vitality test. Until now we learned about the sensibility tests. Okay, sensibility tests. What are sensibility tests? Which helps in determining the nerve sensitivity of the vitality. Vitality means vitality is related to blood supply, whereas sensibility is related to the nerve supply. All your thermal tests, that is heat test, cold test, or your EPTs, or your test cavity, or your anesthetic test. So all the tests what you have learned until now, they talks about the nerve supply to the pulp. So now we are going to talk about the blood supply to the pulp, that is called as vitality tests. The first one that you have to make a note about is laser Doppler flowmetry. It's a non-invasive test because you are not going to cause any damage to the tooth structure, which helps in measuring the blood flow. Okay, it's going to help in measuring the blood flow. How? When you are going to hit a light. Okay, you're going to hit a light, and this light, a part of the intensity of this light will be observed by the red blood cells that are present in the body, which are moving, and some sort of reflection will goes off, and which is detected by the photo detector. Okay, so the drift in the change in the light density or the wavelength, which helps in determining the blood flow. So that is called as laser Doppler flowmetry, which is based upon Doppler's principle, of which we have learned in the 11th and 12th standard. So for the echo, so something is going to come, hit the red blood cells, there will be some deviation, and the echo is going to go back. So that is called is based upon the Doppler's principle, laser Doppler flowmetry. The word clearly says that it determines the flow of the red blood cell. The second important is pulse oximetry. Okay, so pulse oximetry. So they can ask you questions on pulse oximetry now, because most of you are using it, a regularly used thing right now. So similarly, your pulse oximetry is useful for also knowing the pulp vitality. So pulse oximetry is also a non-invasive procedure. is also a non-invasive procedure which helps in knowing the oxygenmetry. Where previously it is flowmetry. Flow, we are knowing the flow. Now it is going to helps in knowing the oxygen saturation levels of the blood which are present in the pulp. So which oxygen means basing upon the concentration of hemoglobin, it's going to help in. So here you can see two types of wavelengths are used. Okay, clearly giving a hint. Okay, one is 660, second one is the 940, right? So what is 660? 660 is red light diode. So you have two diodes. One is red light diode, which is 660 nanometers. 660 nanometers. Other one is infrared diode, which is of 940 nanometers. Most commonly asked questions are these numbers, 660 and your 940. Okay, so what happens here? Okay, what happens here is so once it was asked in the AIMS and PGA, they're basing upon which principle thus this pulse oximetry is going to work. So pulse oximetry is going to work on two principles. Then one is Beer's principle. One is Beer's principles and second one is Lambert's principle. So what is Beer's principle? Beer's principle is nothing but the absorption of a light is directly proportional to the concentration of the sample that is given. So absorption, if the density or the concentration is very high, the absorption of light will be more. If it is less, the absorption of light will be less. So that is the Beer's principle. And the second one is Lambert's law or Lambert's principle. The absorption is proportional to the thickness of the sample. First one is concentration of the sample. Second one is the thickness of the sample. So basing upon these two principles, your pulse oximetry is going to work. So the important points in the pulse oximetry are, it's a non-invasive procedure. It helps in knowing the blood saturation levels. It has two diodes and their wavelengths are important, and it works on two principles, and what is the meaning of those two principles is a very, very important in examination point of view. The next comes, these are few advanced things, but there are chances that because nowadays advanced questions are regularly asked, and most of your advanced questions will be from perio and from endo, perio, cons and oral surgery, preferably when compared to any other subjects, because these are the clinically more oriented subjects. So they're asking questions on this. So that is called as dual wavelength spectrophotometer. So what is the dual wavelength? Okay, the word clearly gives an idea that they have two wavelengths. Okay, so they're dual wavelength. Spectrophotometer is one of the way by which your pulp vitality can be known. So the few important things that you have to make a note when you're talking about this dual wavelength. So this dual wavelength helps in determining the oxygenation of the blood. Oxygenation of the blood at two wavelengths. One wavelength is 760 nanometers and the second wavelength is 850 nanometers. You have two wavelengths. One is 760 and second one is 850 nanometers. And these particular the sensors, they helps in knowing the oxygen levels of the blood at these two levels, that is 850 nanometers and 760 nanometers. And this particular dual wavelength spectrophotometer was able to differentiate the productive values for a normal teeth and an abnormal teeth. So you're going to compare a normal teeth to an abnormal teeth, by which the variations can be gives an idea with other features and the symptoms of the patient, by which you can diagnose the case. So you can ask me what is the difference between this particular thing or pulse oximeter. Okay, so pulse oximeter, the main difference between the pulse oximeter is the blood flow depends upon the pulse, that is pulsation, because the blood flow will increase whenever the pulse is more. Whereas this particular type of dual wavelength spectrophotometer measures the oxygen changes in the capillary blood rather than the supplied blood. Okay, so most your pulse oximeters depends upon the supplied blood. Okay, whereas your pulse oximeter depends upon the supplied blood vessels. Whereas your dual wavelength spectrophotometer, it depends upon the capillary beds. So that is the main difference between the two types of devices, which almost works in the same principle. Okay, so once we are done with this, the next important aspect is TACT, that is tuned aperture computed tomography, okay, which is called as TACT. So the main important is when you're going for this TACT radiograph, what happens is you're going to expose the same teeth in different directions, and by using a software, you're going to combine these all radiographs, which gives a tuned aperture. This is a tuned aperture, different apertures, and you're going to by using a software, you're going to combine all this in a simple. So they can ask you question is how many radiographs are taken in this TACT? 8 radiographs are taken in this TACT. You can see 1, 2, 3, 4, 5, 6, 7, 8. So 8 different angulations. You're going to take a radiograph, and all these are going to be combined to form a single radiograph by using a software which has most of your questions will number of radiographs, number of angulations of images taken in tuned aperture tomography is 8. So compared to many other scenarios, like if you go in detail, so even CT is used in some cases, but the most prone or most commonly used nowadays is the CBCT. Okay, CBCT, of course, we learn in detail about the CBCT in your oral radiology part. Okay, CBCT, okay, cone beam computed tomography is the best way of identifying any radiograph related stuff. So they can ask you, like, among the options, which is the best one to determine the number of canals on the radiograph, or an apical root fracture at which level or anything. The best way is, because this you can see this in a different layers of cross section in the both horizontal or vertical at any level, by which you can clearly identify any sort of abnormality or problem with this. So that is the main advantage, because you will have a different oxals in this, and you can observe at each level, like which level it has started, you can clearly determine. So this is the best thing right now available for an endodontist to know the outcome of the treatment, and it also helps in knowing the prognosis or anything like diagnosis and anything. So the best thing right now to know the anatomy at the best is CBCT for an endodontist. So of course we'll learn in detail about this when I'm talking about the endo related stuff. Yeah, done for now. Signing off, Dr. Srikanth.